Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I'm currently a PGY5 resident at the University of Pittsburgh, and today we will be discussing the evidence base for various radiation regimens for localized prostate cancer. My hope is to go through different groups of trials, so trials that have looked at dose escalation for prostate cancer, trials looking at moderate hypofractionation for prostate cancer. In the modern era, we also can do some extreme hypofractionation or prostate SBRT. And then I'd like to end by talking about which patients may or may not benefit from elective nodal irradiation. My hope is that by the end of this talk, you will hopefully have an understanding of different regimens that are available to prostate cancer patients. And throughout, we will kind of make note of which trials included more low versus favorable intermediate patients, which trial included more unfavorable intermediate or high risk patients. But hopefully at the end of this, you kind of get a sense of what are some available dose fractionation regimens for different prostate cancer patients and who would or would not be a candidate for those. To sort of set the stage for the thought process behind some of these dose fractionation trials, I think it helps to understand the radiobiology of prostate cancer. To understand this, I think it's important to understand the alpha-beta ratio. There's this concept in radiation biology of the alpha-beta ratio, which is the dose where the linear component of cell killing due to a single hit to the DNA equals the quadratic component of cell killing due to a double hit to DNA. And tissues with a higher alpha-beta ratio tend to be less sensitive to the dose per fraction. What does that mean? Tissues with a high alpha-beta ratio, I think of them as the rapidly proliferating tissues. So things that are rapidly proliferating in our bodies like skin cells, the cells lining our GI tract, and also most tumors tend to be rapidly proliferating, and these have a higher alpha-beta ratio. And so when we give radiation, they don't care as much if we're giving 1.8 to 2 gray per fraction, 3 gray per fraction, or even higher fraction, or dose per fraction, right? Obviously, as we give higher and higher dose per fraction, the cell killing is going to be more, but the slope of that killing doesn't change as much depending on whether we're giving a low dose per fraction or a high dose per fraction. Cells with a lower alpha-beta ratio, however, tend to be kind of slower proliferating. So think of most of the normal tissues in our bodies, like our spinal cord, our kidneys. These tend to have a lower alpha-beta ratio, and they're more sensitive to dose per fraction. So if we're giving low doses per fraction, like 1.8 to 2 gray per fraction, they're probably not going to respond as much as if we're giving 5 gray per fraction or 10 gray per fraction. As we increase the dose per fraction, the slope of that survival curve sharply decreases for these lower alpha-beta ratios. Now, we just said that most tumors in our body tend to have a high alpha-beta ratio. So that means that they're not as sensitive to the dose per fraction, and so we can probably effectively kill them just by using that conventional fractionation, 1.8 to 2 gray per fraction. And for years and years, radiation oncology kind of exploited that fact that tumor cells tend to have a high alpha-beta ratio, so they have a lower sensitivity to the fractionation, whereas the normal cells in our body, a lot of them have a low alpha-beta ratio and a higher sensitivity to fractionation. So if we're giving conventional doses, 1.8 to 2 gray per fraction, it's easier to kill the tumor cells, and we can take advantage of those 4 R's of radiobiology, the repair and things like that, to selectively kill the tumor cells at conventional fractionation doses. And we know that we're going to be treating a lot of our normal tissues as well with traditional 2-dimensional and 3-dimensional radiation fields, but that's okay because the normal tissues have a low alpha-beta ratio, they're less sensitive to fractionation, and they have the ability to heal over time between fractions and then in the long term as well. Now, prostate cancer is different than most other tumors because unlike most other tumors that have a high alpha-beta ratio, prostate cancer actually has a low alpha-beta ratio. And if you think about it, it makes sense, right? Prostate cancer is a more slow-growing tumor. It's not going to proliferate as rapidly as your typical head and neck squamous cell carcinoma. It's a much more slow growing tumor, and so it has a low alpha beta ratio. It more imitates the tissues of the normal tissues within our body. And so the estimated alpha beta ratio of prostate cancer is actually closer to that of most of our normal tissues in our body, somewhere around 1.5 to 3. And so that leads to this idea that prostate cancer might then be harder to kill at conventional doses, right? 1.8 to 2 gray per fraction. So the question is, how can we overcome that? And one solution is to potentially continue to use conventional fractionation, but try for some dose escalation. Another technique is to try and utilize hypofractionation, where we actually exploit the therapeutic ratio, and we know that prostate cancer is more sensitive to dose per fraction, and so we go ahead and give it a higher dose per fraction. And so there are some trials looking at moderate hypofractionation, where we're giving more than 2 gray per fraction, so somewhere around 2.5 to 3 gray per fraction. And then there's also ultra hypofractionation and SBRT, where we're giving much higher doses per fraction. So now, with that background in mind, let's start by talking about some of the clinical trials that evaluated dose escalation for prostate cancer. Historically, prostate cancer was always treated with dose-escalated conventional fractionation. So a regimen of 78 gray and 39 fractions, for example, was a pretty typical regimen for prostate cancer more historically. In the modern era, we have good data for moderate hypofractionation, and with moderate hypofractionation, we're able to treat patients within 4 to 5 weeks, whereas in the conventional era, 39 fractions, that takes almost 8 weeks to complete. So in the modern era, we really don't do conventional fractionation for prostate cancer anymore. But before all of the data on moderate hypofractionation came out, and keep in mind that as our radiation techniques have improved also, we've been able to more safely give higher doses per fraction without causing too much normal tissue toxicity. So a lot of these trials that are summarized on this slide are kind of from an older era. And these trials compared lower doses of radiation, so somewhere on the order of 64 to 70 gray, versus higher doses of radiation, somewhere on the order of 74 to 80 gray, and all of the radiation was given at around 2 gray per fraction, so conventional fractionation. And with conventional fractionation, a lot of these trials showed that there was a significantly improved biochemical control with dose-escalated conventional fractionation. Most of these trials actually did not show any overall survival benefit. And as we will see in a lot of different prostate cancer trials, it turns out that it's actually hard to show an overall survival benefit for prostate cancer specifically, because a lot of these men end up living for a long time. A lot of them end up dying of other comorbidities. And so a survival benefit becomes very challenging to show for a disease site with such a good overall prognosis. But biochemical control ends up being a very significant endpoint for prostate cancer. And most of the trials that we will talk about tend to show a biochemical progression-free survival benefit. So along those same lines, in an older era where we were only using conventional fractionation, dose-escalated therapy, so think 78 to 80 gray and 2 gray per fraction, that showed an improvement in biochemical control. I don't want to spend too much time on the details of dose escalation in the conventional fractionation trials. I just think it's important to understand that historically, dose-escalated conventional fractionation was the standard of care. And in the modern era, we have really moved away from conventional fractionation, and most patients are receiving moderately hypofractionated regimens just because it has been shown to be non-inferior, as we will talk about, and it is by far more convenient for our patients, and it almost cuts their overall treatment time in half. In the modern era, I think there are a few different applications of quote-unquote dose escalation that are still clinically relevant and still sometimes utilized, and that I think are really important to be aware of. So the first trial that I want to kind of spend more time on is what is called the FLAME trial. And the FLAME trial was a phase 3 superiority randomized controlled trial that studied the utility of a focal boost to the intraprostatic tumor. So you might hear this mnemonic DIL, which stands for the dominant intraprostatic lesion. And there's this idea of boosting the DIL, or the dominant intraprostatic lesion. And that's essentially what was done in the FLAME trial. So this trial ran from 2009 to 2021, and they enrolled almost 600 patients with intermediate and high-risk prostate cancer. 85% of the patients on the trial were high risk, however. And they randomized them to either standard radiation, 77 gray and 35 fractions to the prostate, or a standard radiation plus boost arm. So they got 77 gray and 35 fractions to the prostate, along with a 95 gray simultaneous integrated boost to the macroscopic tumor. Now, a very important aspect of this trial is that they wanted to provide an isotoxic boost, meaning they did not want to cause worse toxicity with such a high boost. And so they had key organ at-risk constraints. The rectum V77 was less than 1 cc, the V80 for the bladder was less than 1 cc, and the urethra dose, which they added in future protocols based on an analysis of the FLAME outcomes, but the dose was V80 for the urethra should be less than 0.1 cc. So rectum V77 less than 1 cc, bladder V80 less than 1 cc, and the urethra V80 less than 0.1 cc. And very importantly, they prioritized the OAR constraints over the coverage of the 95 gray SIB volume. So interestingly, only 20% of the patients in the boost arm actually reached that 95 gray dose. The rest of them were undercovered because of the OAR prioritization. And the PTV was prescribed, the prostate was prescribed 77 gray, but any region of the PTV that overlapped with the rectum was only prescribed 70 gray. So the key was really to perform an isotoxic boost. The results of the FLAME trial showed that providing that isotoxic intraprostatic boost improved the 5-year biochemical disease-free survival. So the biochemical disease-free survival was 85% with the 77 gray and 35 fraction standard arm versus 92% in the arm that got the simultaneous integrated boost. And that was significant. Not surprisingly, as we just talked about, there was no significant difference in the overall survival or the distant metastasis-free survival or prostate cancer-specific survival. They importantly did not have any significant differences in late GU or GI toxicity. And so again, keep in mind that this was an isotoxic boost. So they did not worsen toxicity by trying to provide the simultaneous integrated boost. So that's really important if you're ever planning something like this, that they prioritize the organ at risk constraints. Now, they did perform a post hoc pattern of failure analysis. And what they realized is that there was a dose-response relationship that they saw between the D98% to the GTV and local failure, as well as regional and distant metastasis-free survival. So basically, if the GTV was better covered, then they were less likely to have local failure, regional failure, or distant metastasis. So as the focal boost dose approached 85 gray or higher, the local failure approached 0, and the risk of distant metastasis approached less than 10%. So the FLAME trial, in conclusion, delivered an isotoxic boost to the prostate, 77 gray and 35 fractions to the prostate, with up to 95 gray of a simultaneous integrated boost to the GTV as seen on T2. And they improved biochemical disease-free survival without increasing toxicity. And most of the patients on this trial were high risk. Now, keep in mind, this is more of a conventional dose fractionation. There are some ongoing trials that are looking at boosting the GTV within the prostate using moderate hypofractionation. So I believe there's a Delineate trial and an Arrow 2020 trial. There's also in the NRG GU0010 protocol that's looking at patients with unfavorable intermediate risk prostate cancer and kind of assessing whether we can escalate or de-escalate their systemic therapy based on the Decipher score. There are some guidelines on treating patients with a boost with moderate hypofractionation. So the data on providing a flame-like boost using moderate hypofractionation is not available as phase 3 data just yet. I think there are practitioners out there, however, who sometimes will extrapolate the flame data in the conventional fractionation kind of regimen and apply that to moderate hypofractionation and similarly provide a flame-like boost, but using moderate hypofractionation. It's just important to realize that when we do that, it's by extrapolating data, it's not yet based on phase 3 data. And I think it's always really important to remember that in FLAME, they prioritize the organs at risk, and that's how they were able to provide a quote-unquote isotoxic boost. Also, keep in mind who they were treating with this protocol, and although the trial allowed for including both intermediate and high-risk patients, 85% of the patients on this trial were high risk. And so if we're thinking about providing kind of a SIB to the intraprostatic tumor, I think it's really been studied in more high-risk patients. And so definitely if someone walks in with favorable intermediate cancer, we probably would not be offering this to them. Another trial that I think is still very relevant in the modern era, but that looks at dose escalation, is the Ascend-RT trial. So this was a trial that compared dose-escalated external beam versus an LDR brachytherapy boost. So similar to FLAME, this trial also included mostly high-risk patients. 69% of patients were high risk, and then they had 31% intermediate risk, but most of them were unfavorable intermediate risk. So unfavorable intermediate to high-risk patients, and they randomized them to either get dose-escalated external beam versus LDR boost. So in both arms, they started out with 46 gray and 23 fractions to the prostate, seminal vesicles, and also all of the pelvic lymph nodes. And then in the dose-escalated external beam arm, they went on to receive a total of 78 gray and 39 fractions just to the prostate. And then in the LDR boost, after the initial pelvic radiation, they went on to receive an iodine 125 LDR prostate brachytherapy boost. So the prescription dose was 115 gray. That was the minimum peripheral dose to the prostate. And this LDR brachytherapy boost was given 2 to 3 weeks after completing pelvic radiation. All of the patients also received a year of hormonal therapy, and the primary endpoint was biochemical progression-free survival. And the definition of biochemical progression-free survival that they used is known as the Phoenix definition, which is a very common definition that we use to define recurrence after radiation. So after radiation, the PSA typically does not drop to 0, but instead it drops to a low point, and that lowest point is known as the nadir. The nadir plus 2 nanograms per milliliter, 2.0 nanograms per milliliter, is what is defined as the Phoenix definition. So you trend the PSA and you find the nadir, so whatever the lowest point is, and after that nadir, if it goes up more than 2 points, that's defined as a recurrence. The results of the Ascend-RT trial showed that when we compare, remember, and these are both of the arms are looking at dose escalation. One is with LDR, one is with external beam radiation. And what they found is that the 15-year biochemical progression-free survival was significantly improved in the arm that was treated with low-dose rate prostate brachytherapy. So the 15-year biochemical progression-free survival was 80% with LDR versus 53% with the dose-escalated external beam radiation, and that was statistically significant. Now, if you look at the Kaplan-Meier curve, what you'll see is that the curves are very, very close together for around the first 5 years, and then after 5 years is when the curves start to separate. They did do an analysis, and they found that there was still a similar magnitude of benefit when they stratified based on the intermediate versus the high-risk groups. And once again, biochemical progression-free survival was the only significantly improved endpoint. So there was no significant difference for the overall survival, the case-specific survival, or distant metastasis-free survival. In terms of toxicity, this is important too. So although the brachytherapy arm had improved 15-year biochemical progression-free survival starting at around 5 years out, They also had significantly worse grade 3 plus GU toxicity. So it was 18% in the LDR arm versus 5% in the external beam arm. And this was late GU toxicity. So they had significantly increased risk of urethral stricture, around 9% risk, pad usage, as well as late catheterization. There was not any significant difference in terms of late GI toxicity or sexual function. It was really worse GU function and more of those obstructive symptoms that we know are exacerbated by brachytherapy, right? So urethral stricture, needing to use a pad, as well as late catheterization. So the conclusion of Ascend-RT, which remember compared two types of dose escalation, escalated external beam radiotherapy versus an LDR boost. And they found improved biochemical progression-free survival, as well as worse urethral stricture and other obstructive urinary symptoms with the LDR arm. And the curves for brachytherapy separated after 5 years. And most of the patients on this trial were high risk, as well as unfavorable intermediate risk. So I think based on the Ascend-RT trial, there's certainly a rationale to offer an LDR boost to patients with either unfavorable intermediate or high risk prostate cancer. I think that these patients need to be selected very carefully, however. So in general, when we're selecting patients for brachytherapy, it's really important to assess their baseline urinary function and keep in mind that if they are already having a lot of problems from BPH, if they have obstructive symptoms, those are likely to get even worse with brachytherapy. So those patients are probably not good candidates for an LDR boost. I think the other element to sort of keep in mind is that, remember, these curves separate after around 5 years. So if we don't expect patients to derive a benefit from this, from providing an LDR brachytherapy boost, then it's probably not worth offering. I think this treatment really should be reserved for patients that are very young, very good performance status, patients whom minimizing the chance of a biochemical recurrence is really, really important because we want to maximize their chance of cure. So patient selection for this, I think, is critical. So that's everything I wanted to talk about in terms of dose escalation. Just to quickly summarize, conventional fractionation, in the era of conventional fractionation, dose escalated radiotherapy was really the standard of care, and it improved biochemical control compared to lower doses. In the modern era, we've really moved towards hypofractionation and moderate hypofractionation, which we're going to talk about here in a second. But I think there are some utilities of dose escalation that are still important. So we talked about the FLAME trial that used an external beam boost to the intraprostatic lesion that was visualized on a T2-weighted MRI. And then we also talked about the Ascend-RT trial that compared dose-escalated external beam to an LDR brachytherapy boost and showed a benefit as well as worse toxicity with an LDR brachytherapy boost. So I think, remember that the FLAME and the Ascend-RT trial both included the majority of patients with high-risk prostate cancer as well as some patients with unfavorable intermediate-risk prostate cancer. So it's really those higher-risk patients that we should even be thinking about potentially boosting. And if we do boost, these are two different approaches that we have. So either external beam boost or a brachytherapy boost based on FLAME as well as Ascend-RT. Moving on now, let's talk about some of the trials that give us regimens for moderate hypofractionation. And as we've said time and again, these are really the trials that I think people fall back on in the modern era, and most patients, if not all, are getting prostate radiation using moderate hypofraction regimens at the very least. There are 3 key trials that looked at moderate hypofractionation, and from these 3 trials, we have 2 potential dose regimens. So remember, moderate hypofractionation, we're giving around 2.5 to 3 gray per fraction. So slightly higher dose per fraction than with conventional fractionation. So RTOG 0415 gave 70 gray and 28 fractions, so that's 2.5 gray per fraction. The other 2 trials are PROPHET and CHIP trial, and both of those trials delivered 60 gray and 20 fractions, so 3 gray per fraction. So the first trial we'll talk about here is RTOG 0415, and the regimen from this trial, remember, is 70 gray and 28 fractions. So RTOG 0415 took patients with predominantly low-risk prostate cancer, and they randomized them to conventional radiation, 73.8 gray and 41 fractions, versus hypofractionated radiation, 70 gray and 28 fractions. And what they found is that the two regimens were non-inferior in terms of both disease-free survival as well as biochemical failure. The disease-free survival was right around 80% in both of the arms, and the 5-year biochemical failure rates were right around 7% in both of the arms. Now, on the initial report, they found worse late grade 2 and 3 GI and GU events in the hypofractionated radiotherapy arms, but the long-term reports actually showed no significant difference in terms of grade 3 or worse toxicity. And there were also no significant differences in the patient-reported quality of life outcomes. And so really, from the RTOG 0415 trial, we found that the disease-free survival was non-inferior for 70 gray and 28 fractions compared to a more conventional regimen. So the key is to remember that RTOG 0415 established 70 gray and 28 fractions as an acceptable regimen for moderate hypofractionation. The next trial looking at hypofractionation that we'll talk about is POPRT, which studied 60 gray and 20 fractions. And this trial enrolled predominantly patients with intermediate risk prostate cancer, and they randomized them to conventional 78 gray and 39 fractions versus 60 gray and 20 fractions. And the conventional arm took almost 8 weeks. The 20 gray or the 20 fraction arm, 60 gray and 20 fractions, took only 4 weeks. None of the patients in this study received ADT because ADT was not permitted. And what the results showed is that the biochemical progression-free survival was non-inferior with 60 gray and 20 fractions compared to 78 gray and 39 fractions. Once again, the 5-year biochemical progression-free survival was right around 85% in both arms, and they actually found no significant difference in terms of GU toxicity. They found worse grade 2 or worse GI acute toxicity with the hypofractionated arm, but then worse late toxicity with the conventional arm. And so, POPRT was another study that kind of established an additional option for moderate hypofractionation. So RTOG 0415 established 70 gray and 28 fractions. POPRT looked at 60 gray and 20 fractions and found a non-inferior biochemical progression-free survival when compared to conventional fractionation. They did not find any significant differences for late grade 3 or worse GU or GI toxicity. The last trial that we'll talk about here is the CHIP trial, which also looked at 60 gray and 20 fractions. But I think this trial is a little bit interesting because they took mostly intermediate risk localized prostate cancer, and they actually had 3 arms rather than 2. So the conventional arm got 74 gray and 37 fractions. They had 2 moderately hypofractionated arms, so either 60 gray and 20 fractions or drop a fraction and do 57 gray and 19 fractions. And most patients did receive 3 to 6 months of ADT. What they found is that 60 gray and 20 fractions was non-inferior to conventional fractionation in terms of biochemical progression-free survival. However, the 57 gray and 19 fractions was not. So the biochemical progression-free survival was 88% with conventional, 91% with 60 gray, and 86% for 57 gray. So 57 gray and 19 fractions was not non-inferior, but 60 gray and 20 fractions was non-inferior. In terms of toxicities, the acute toxicities peaked earlier in both of the hypofractionated arms. They found slightly worse acute bowel toxicity with the hypofractionation, but similar acute bladder toxicity, and there was no significant difference in the late toxicity. So CHIP, again, just like POPRT, kind of established 60 gray and 20 fractions as a potential moderate hypofractionation regimen. They found that the biochemical progression-free survival was non-inferior with 60 gray and 20 fractions, but it was not non-inferior with 57 gray and 19 fractions. And it also showed that the acute toxicity sort of peaked earlier with the moderate hypofractionation and perhaps slightly worse acute bowel toxicity. I think the big takeaway from the RTOG 0415, PROPHET, and CHIP trials is that moderate hypofractionation is non-inferior to conventional fractionation. Now, when these trials were first published, and as you saw in the inclusion criteria, a lot of the patients that were included on these trials were low or intermediate risk. And so initially there was hesitation to apply them to high-risk patients. Since then, there have been additional trials published, and some of those are shown in this table here, and they also included high-risk cancer patients. And so now if you look at the ASTRO guidelines for moderate hypofractionation, there is an agreement that moderate hypofractionation can be used in patients with high-risk prostate cancer as well. For patients with high-risk prostate cancer, I think dose escalation with either brachytherapy boost or a focal boost to the tumor inside of the prostate, I think those options are still on the table. But moderate hypofractionation is also an option on the table. And you'll see that a lot of different attendings have different practices when it comes to managing high-risk prostate cancer. And some people do offer brachytherapy boost. Some people do, in select cases, offer kind of a flame-like boost. But I think the big takeaway is that moderate hypofractionation is also non-inferior. Also shown in this table are some of the bladder and rectal dose constraints that were used in these various trials. One point that was kind of emphasized in my training is that it's important to understand how the organs at risk were contoured in the different trials. So for RTOG 0415, as well as for the CHIP trial, the constraints were based on contouring the entire bladder or the entire rectum. But for the PROPHET trial, the constraints are based on the wall, so the bladder wall or the rectal wall. And my silly mnemonic for remembering this is that if you want to make a PROPHET, you have to be a little more skimpy or cheap. And so in PROPHET, they were more skimpy with their contours, and they just contoured the wall. So keep in mind when you're doing these plans also to pay attention to what the organ at risk, how it was contoured, and then what the constraint that was used. So the next question, kind of in a chronological order, I think that was looked at was the utility of extreme hypofractionation. So now think SBRT, and what is the data for prostate SBRT, and when do we actually utilize this? So let's talk about that. There's a trial called Hypo-RTPC that took patients with intermediate to high risk prostate cancer not receiving ADT and randomized them to 78 gray and 39 fraction conventional radiation versus an extreme hypofractionation regimen of 42.7 gray and 7 fractions delivered over 1 to 2 weeks. They utilized 7 millimeter PTV margins everywhere, and importantly, around 80% of the patients were actually planned using 3-dimensional radiotherapy. What they found is that ultra hypofractionation was non-inferior in terms of failure-free survival, so it was just around 84% in both arms, but there was significantly worse acute toxicity with ultra hypofractionation, as well as worse urinary toxicity at 1 year. So the acute GI and GU toxicity were worse with ultra hypofractionation, and at 1 year, there was significantly worse GU toxicity as well. At 5 years, the toxicities were equal between arms. So Hypo-RTPC showed us that, the extreme hypofractionation, 42.7 gray and 7 fractions, is non-inferior for failure-free survival, but they do have worse acute toxicities and worse 1-year GU toxicity as well. I think for this trial, it's important to keep in mind the planning that was used. So remember, 80% of them got 3D conformal radiotherapy. In the modern era, if we're doing SBRT, we're probably using IMRT, probably like a VMAT plan or something like that. And so our doses are going to be much more conformal. Also, we're using smaller margins. They use 7 millimeter PTV margins in all directions. We typically utilize smaller PTV margins posteriorly towards the rectum. And with SBRT, the margins are much smaller as well. And so, I think this was kind of the first step, but it's not the standard that we follow. There are some ongoing trials in the prostate SBRT world that are taking patients with localized prostate cancer and treating them with SBRT. So there are different PACE trials. So in the lower intermediate risk group, patients that may be candidates for surgery are actually getting randomized on the PACE-A trial, where they're randomized to surgery versus SBRT. Patients that are not getting considered for surgery are going on PACE-B, which was published, where they are randomized to conventional radiotherapy or SBRT. And then in the intermediate to high risk arm, where we're giving hormonal therapy, patients are actually getting randomized on PACE-C, where they're getting randomized to 60 gray and 20 fraction, so moderately hypofractionated radiation versus SBRT. So PACE-B took patients with low or favorable intermediate risk prostate cancer. So these were patients that were not getting ADT and no ADT was allowed. And they were randomized to conventional or moderately hypofractionated radiotherapy versus prostate SBRT. And the dose for prostate SBRT is important. So the PTV was prescribed 36.25 gray in 5 fractions, given either daily or every other day. And then a 40 gray boost was given to the CTV. So the CTV was the prostate only for low risk patients, or the prostate plus the proximal 1 centimeters of the seminal vesicles for intermediate risk patients. And the margins were smaller than what was used for the conventional or moderately hypofractionated arm. So they used 4 to 5 millimeter PTV margins with 3 to 5 millimeter margins posteriorly towards the rectum. What they found is that the toxicity was similar between the arms. The acute toxicity peaked 1 to 2 weeks earlier with SBRT, and then the GI and GU toxicities were very similar between the two arms. And then the 5-year biochemical progression-free survival was about 95% in both arms. And this was presented in a later publication, but the 5-year biochemical progression-free survival was non-inferior for SBRT compared to the moderate or conventional hypofractionation. So toxicities are similar and biochemical progression-free survival is excellent and it is non-inferior. Keep in mind that PACE-B included low or favorable intermediate risk prostate cancer patients. So at this time, we don't actually have data for treating high-risk patients with SBRT off trial, and PACE-C, we're kind of waiting for the results. PACE-A, I shouldn't say there's not a publication because the toxicity results have been published. Remember, PACE-A compared surgery versus SBRT for low and favorable intermediate. And PACE-A showed that the SBRT arm was superior in terms of urinary continence and sexual bother score, but patients with SBRT reported more bowel bother at 2 years. And so the outcome results are still maturing, I think, and we're also waiting for PACE-C, which looked at more unfavorable intermediate and high-risk patients. So for the low risk and for the favorable intermediate risk patients, I think PACE-B gives us a good option for prostate SBRT in these patients as well. So we have lots of options, right? I think across the board, moderate hypofractionation is an option for pretty much everyone with prostate cancer, localized prostate cancer, that is. For patients with low or favorable intermediate risk, we have 5-fraction regimens, so prostate SBRT. For patients with unfavorable intermediate or high risk, we have consideration for a brachytherapy boost, consideration for an external beam boost as per FLAME. And as if we don't have enough options, I'd like to briefly discuss another option, which is consideration for brachytherapy as monotherapy. RTOG 0232 was a randomized trial that took patients with favorable intermediate risk prostate cancer and randomized them to either 45 gray external beam radiation to the prostate and seminal vesicles, followed by an LDR brachytherapy boost, or LDR brachytherapy alone. And for these favorable intermediate risk patients, what they found is that there was no significant improvement in the 5-year progression-free survival with external beam radiotherapy. So the progression-free survival was 86% for combined modality versus 83% for LDR monotherapy, and that was not significant. And as you can imagine, having external beam plus brachytherapy worsened toxicity compared to brachytherapy alone. So they had both significantly worse grade 2 plus as well as grade 3 plus toxicity. So RTOG 0232 for favorable intermediate risk patients, brachytherapy alone is an option. And we know that for favorable intermediate risk patients in general, we tend to be thinking about monotherapy. So whether that monotherapy is surgery alone, radiation alone in all kinds of forms, whether that is moderately hypofractionated, SBRT, or brachytherapy alone. And so RTOG 0232 is just further evidence for that brachytherapy alone monotherapy in favorable intermediate risk patients. I think getting into the details of prostate brachytherapy is a little bit beyond the scope of this particular talk. We might have to come back and do a separate talk on prostate brachytherapy. But just for reference, I wanted to include this slide just to show some of the sources that we use for LDR brachytherapy, what their average energies and half-lives are, the different doses that we would utilize if we're giving them as a monotherapy versus as a boost. Keep in mind that when we're selecting patients for brachytherapy candidacy, we really want to take into account their pre-existing urinary symptoms, so kind of their baseline function, as well as their anatomy and their prostate volume. And brachytherapy does cause worse obstructive and irritative urinary symptoms. So if they have a lot of those at baseline, or if they already have an enlarged prostate, they're probably less optimal candidates for brachytherapy. Just to compare, again, without going into excessive details, HDR brachytherapy is also an option. And with HDR brachytherapy, we're not permanently implanting radioactive seeds, but rather we're temporarily introducing a brachytherapy source, which in this case is a higher energy source, iridium 192, similar to what we do for certain gynecological cancers. So the advantages of HDR brachytherapy is that it's not a permanent implant, and so you're not relying as much, or the dose distribution is not as much affected by how the seeds are permanently implanted and how the prostate anatomy changes over time as inflammation sort of starts up at the time of insertion and then subsides over the weeks after. HDR brachytherapy, you insert the needles, you insert the source, and what you see is kind of what you get in terms of your dose distribution. So you get a little bit more control, I think, with HDR brachytherapy compared to LDR. The downsides of HDR compared to LDR is that when we're doing brachytherapy as a monotherapy, with HDR, we do not have a great single fraction regimen. There is a double fraction regimen, there's 4 fraction regimens. The single fraction regimen was studied in a phase 2 trial and was actually inferior. So if we're doing HDR as monotherapy, we typically need at least 2 trips to the operating room, which is a downside. If we're giving HDR as a brachytherapy boost, then certainly we can do 1 fraction, and there's evidence for that. But that is one thing to keep in mind, that we can't do it as a single fraction for monotherapy. In terms of side effect profile, I think HDR, because the radioactive source is not remaining in the patient and staying active for weeks to months, the toxicity tends to peak sooner. And they tend to have less acute GU as well as less long-term bowel toxicity with HDR. So pros and cons, again, institutional practices vary depending on what they have available. But I think it's good to kind of know that both LDR and HDR are options for brachytherapy as well. Okay, so before we come to a conclusion, the last topic that I want to discuss is elective nodal radiation and when we might consider adding elective nodal irradiation to the pelvis for patients with localized prostate cancer. RTOG 9413 was a 2x2 randomized trial that ran in the late 90s, and they included patients that had greater than 15% estimated risk of lymph node involvement by the Roche formula. So there are a few different Roche formulas, some for risk of lymph node involvement, some for risk of distant involvement. The lymph node risk, as determined by the Roche formula. The calculation is 2/3 times your PSA plus your Gleason score minus 6 times 10. And if that number gives you something that's greater than 15%, then those patients would have been included in this trial. And by virtue of this formula, they ended up enrolling mostly high-risk patients. Now, the trial design was a bit convoluted. They randomized patients to either whole pelvic radiotherapy versus prostate-only radiotherapy with conventional fractionation, because this was in the late 90s. And they also randomized them to neoadjuvant versus adjuvant hormone therapy for a total of 4 months. And initially, they found that the addition of pelvic radiation improved their 4-year progression-free survival, but on long-term follow-up, that effect was sort of lost. And so the significance or the progression-free survival benefit of whole pelvic radiation was kind of lost over time. The significance was lost over time. And unfortunately, the trial was not really powered to compare all 4 arms. So I think this trial is, first of all, a little bit old and outdated, and these results were difficult to interpret, and they actually generated quite a bit of controversy, and pelvic radiation was quite controversial. The trial that I have seen applied in clinic more frequently is actually POPRT, which is a trial from India that randomized patients to whole pelvis radiation versus prostate-only radiotherapy. The PORT, don't confuse that with post-op radiation. It's not post-op, it's whole pelvis radiation versus prostate-only radiation for therapy for patients with localized prostate cancer. So who was included in POPRT? Again, these were pretty much high-risk patients, and they also used the Roche formula. So it was patients with a 20% or higher risk of lymph node involvement as calculated by the Roche formula. And they randomized them to either 50 Gray and 25 fractions to the nodes with a 68 Gray simultaneous boost to the prostate. So that's kind of a moderate hypofractionation regimen right there, versus prostate-only radiotherapy, 68 Gray and 25 fractions. All of the patients received a minimum of 2 years of ADT, and 80% of the patients also had PSMA PET staging to rule out node-positive disease, and most of them also were planned using IMRT. So these were kind of higher risk patients than what were included in RTOG 9413. The results of POPRT showed an improved biochemical failure-free survival, disease-free survival, and distant metastasis-free survival with whole pelvic radiotherapy. Overall survival was not significantly improved. As you can imagine, there were some worse grade 2 late GU toxicity seen with whole pelvic radiotherapy, but there were no significant differences in acute GI or GU or late GI toxicity. The numbers for biochemical failure-free survival were 95% with pelvic radiation versus 81% without. Disease-free survival was 90% with pelvic radiation versus 77% without. And the distant MET-free survival was 96% with pelvic radiation versus 89% without. And the overall survival was not significantly different. It was right around 92% in both arms. And the rate of late G2, grade 2 plus GU toxicity was around double with pelvic radiation. So POPRT, I think, is a more straightforward trial to interpret, and this trial I have seen used in clinic to kind of justify offering pelvic radiotherapy to specifically for high risk or very high risk patients. So this is something that I think is important. Now, of course, when patients actually have positive pelvic nodes, and nowadays we're using PSMA PET to screen for this, if patients do have node-positive disease, then we're also treating the pelvis, and we're often boosting the gross nodes that we see lighting up on the PET scan. But keep in mind, this is for patients that are node negative based on their staging, but they are at a high risk of lymph node involvement. These are the patients that we're offering whole pelvic radiotherapy. There's an ongoing randomized trial. There's actually a few trials that are kind of ongoing and studying this question of who should we be offering elective nodal radiation to the pelvis for patients with high-risk prostate cancer. currently RTOG 0924 is one of these trials that's currently ongoing and close to approval. They are enrolling intermediate and high-risk prostate cancer patients. All of the patients are going to be receiving a boost either with external beam radiation or with brachytherapy. And they're sort of randomizing them to either get prostate-only radiotherapy or radiation to the prostate and the pelvis. And their primary endpoint is overall survival, which, remember, as we've talked about, it is exceedingly difficult to show a survival benefit in prostate cancer because a lot of times, prostate cancer just has such a good overall prognosis that it's really not an overall survival endpoint that we're affecting. And as you saw in a lot of the trials that we talked about, they had a biochemical progression-free survival benefit from certain regimens, but they did not have any significant differences in overall survival. So it'll be interesting to follow this trial. I think pivotal boost, and then there's a RTOG AFU 23 trial that's going on as well. It'll be interesting to see the results of this. But until then, I think POPRT is one of the best trials that we have to kind of think about who should get pelvic radiotherapy. So that brings us to an end. That was kind of all of the important literature that I was hoping to summarize. I'm sure there are other avenues that we could have gone, and there's a lot of other trials that we could have also included. We could have gone into more nitty-gritty details about each of the individual ones I discussed here. I think it's hard to kind of, in a nutshell, present all of the radiation regimens that are available options for treating prostate cancer. I think if you take anything away, it should be the following two things. Number one, prostate cancer therapy is highly individualized based on the patient's risk stratification. So that's probably one of the most important things to consider when thinking about what treatment is an option, for localized prostate cancer. First, you need to answer, what is the patient's risk? And then from there, the second thing you should take away is that there are a lot of options. And that is why prostate cancer is so hard as clinicians to kind of present to patients, just because there are so many options. And it's even harder, obviously, from the patient's standpoint to process all of that information and make the right decision for themselves. So as physicians, I think it's our job to be as informed as we can be about all of these different options, educate the patient about what is an option that is based on institutional practices, what they might hear about if they were to go to other institutions, and kind of present the options to them as fully as possible to help them make an informed choice. Very briefly then, let's go ahead and review what all of those options that we talked about, what they actually are. So remember, we started by talking about conventional fractionation and how in the conventional era, dose escalation was the standard of care for prostate cancer because we know that it has a low alpha beta ratio, and so it tends to be harder to kill with conventional doses. In the modern era, we are not really utilizing conventional fractionation much more. We have moved towards moderate hypofractionation. So at most, patients are getting anywhere from 4 weeks to 5.5 weeks of radiation using moderately hypofractionated regimens such as 70 gray and 28 fractions or 60 gray and 20 fractions. Some patients with intermediate risk can be further hypofractionated and may be candidates for SBRT. So with SBRT, we're doing just 5 fractions. And some patients may also be a candidate for brachytherapy as a monotherapy. And remember, with brachytherapy, we have both the LDR permanent seed implants or the HDR temporary seeds, which are both options from a brachytherapy perspective. And remember, monotherapy is really for low risk or favorable intermediate risk patients, as well as some unfavorable intermediate risk patients, although for those we add ADT, which we will discuss in a future talk. Although we don't really utilize dose escalation so much anymore, like dose escalated conventional radiation, there is still utility for dose intensification in certain high risk patients. That dose intensification can be done as a brachytherapy boost, as in Ascend, or it can be done as an external beam radiotherapy boost, as in the FLAME trial. And remember, FLAME still used pretty much conventional fractionation, but in the modern era, we are also studying moderate hypofractionation with an escalation to the intraprostatic tumor. So dose intensification still has utility in the modern era for certain high risk or greater patients. Also for high risk patients, something that we should consider is elective pelvic nodal RT, especially if they have a higher risk of metastasis to the lymph nodes. So consider elective pelvic nodal radiation as in the POPRT trial, and keep in mind that we are awaiting some currently ongoing trials to kind of further guide who should get elective nodal radiotherapy. That brings us to an end for now. Hopefully this talk was helpful in kind of elucidating various options that we have for treating prostate cancer with radiotherapy. Hopefully we were able to kind of emphasize when patients are candidates for certain therapies and when they are not candidates, and kind of what the data is for that. In a future talk, so the next talk that I'm hoping to do and release here soon is going to be on systemic therapy for localized prostate cancer. So when we put together the information for the radiation regimens we have available, as well as the data for systemic therapy, which I will cover in the next talk, hopefully that gives us the tools we need to take care of patients with localized prostate cancer. Thank you so much for your time and attention.